We'll call the May Board of Health meeting to order. For the record, there's a copy of the Open Meetings Act on the north wall of the legislative chambers. And we did have notice in the Daily Record. With that, roll call.
Wade.
Here.
Festerson. McNally. Rogers.
Here.
Weiss.
Here.
Jones. Wilkin.
Here.
King.
Here.
Espinoza.
With that, we'll go to item 2, an approval of the minutes from the April meeting. Is there a motion to approve?
So moved.
Motion by Wade, is there a second?
Second.
Second by Weiss.
Okay.
Roll call.
You said Wade motioned?
Yep.
Okay. Okay. Wilkin.
Abstain.
Wade.
Yes.
Rogers.
Yes.
King.
Abstain.
Weiss.
Yes.
Okay.
Item 3 is approval of the items. We have items A through F. If no one needs to approve anything, accept a motion to approve items A through F.
So moved.
Motion by Wade, just a second.
Second.
Second by Wilkin. Roll call.
Hang on. Where was she? Okay. Rogers.
Yes.
Wilkin.
Yes.
King.
Yes.
Weiss.
Yes.
Wade.
Yes.
Okay.
We'll go to presentations and item A and the department strategic plan. Morning.
Morning.
David Johnson, I'm the division chief of the Division of Public Health Strategy, Innovation, and Planning. And this is Catherine Plumley. She's our accreditation coordinator, and she also oversees our quality and performance management work. And she also co-facilitated our strategic planning with Jennifer Moore. So we're going to take a really quick run through the strategic plan and the strategic plan priorities. Moving on to the next presentation. So I just wanted to remind everyone kind of where we started. So the department engaged in reaffirming our core values and redefining what our overarching objective, long-term kind of wicked objective is for the department. That became the foundation of our strategic plan. This just gives kind of a quick snapshot in time on where we are, where we were, and where we're headed. So we're currently moving away from the planning and into the strategic action phase of this strategic plan with implementation. One of the main things that we wanted to highlight for everyone today, and one of the things that I think makes our current strategic plan really important and really unique, is that we had such high levels of engagement from across the entire department. So we saw about 95% of the health department workforce actively engaged in the formation of this strategic plan. We also saw engagement from this board and from 13 key community partners. So we'll dive into these really briefly one-on-one, but we just wanted to give you a quick overview that we identified 6 overarching strategic priorities.
And this slide just gives you an idea of the hierarchy within the strategic plan. So we have those 6 priorities. Each priorities have a few goals under those. And then within each goal are annual strategies that we will be implementing with their own activities. And then the performance management really is the way we're going to measure our success. I do want to quickly note that the strategic priorities and goals are will last the entire 3 years. It's those annual strategies that will be subject to change based on the results of our findings, based on environmental factors, that sort of thing. So real quick, this is just an example of that we have planned out year 1, year 2, year 3 strategies for each of the priorities, but again, those will be subject to change. And I do want to highlight that employee feedback that we got from 95% of employees is really what fed directly into what those goals and strategies are. But this is just an example. So for our first priority, it is data-driven solutions. And one of the things we really want to highlight here is that we are seeking to be more transparent with our data, enhance our data-driven storytelling, and really use that data to enhance our communication, analysis, and visualization.
The next priority, and I want to just note that these priorities aren't in any particular order, so it's not like any were prioritized over the others. This next one is community engagement. This really asks us to recognize the areas where we've fostered strong and authentic community trust, and then commit to working to gain and build stronger community trust in communities where we maybe don't have an impact, or areas where we need to be responsive to community-driven need.
The next priority is healthy and vibrant work culture. Again, we're working on building that trust even within our own organization, amongst our staff and our coworkers and our teammates. And we really also want to highlight that we're working towards career development and personal development of our staff to make our organization better.
This next one's probably not a surprise to anyone, but it's innovative funding. We recognize that public health has always required us to be nimble and creative in how we leverage the resources that we have to meet community-driven need. Certainly our current climate is no different. Well, it is different, but we are ready to address those needs, but it requires us to think outside of the box. One of the strategies that I am going to highlight that came out of our listening sessions really does revolve around the formation and creation of a foundation to support the ability for us to leverage funds and use them in the ways that are necessary for our department to move quickly and also meet those needs of the community quickly and rapidly. So I did want to call out, that's probably the only strategy we're going to specifically call out today, but that is one that we think is really important, and we did hear that from our workforce pretty loudly. Next is improved workspaces. I want to be very clear, this doesn't necessarily mean moving into a bright new shiny building. What it means is if that opportunity were to present itself, wonderful, but also recognizing the space that we do have, the opportunities we have to embed our teammates in
co-working environments with community partners, the ability to continue to leverage work from home so that we are able to maximize the resources that we do have. And it also talks about making an environment that is safe and welcoming to our workforce.
The last priority is policy and procedure improvement. And I'll just highlight that, now that we're out of the pandemic, we want to get back into those regular routines and start reviewing those policies, improving those policies. And we have, this is an example where it's a strategy in the strat plan, but we had already started the policy review committee. So that work is already underway. Next, I want to talk about a little bit about how we're going to actually implement and not just have this be a strat plan that sits on the shelf and collects dust, but we're going to be utilizing 90-day projects, and essentially the strategies that are in the strategic plan almost verbatim translate into, okay, we're going to turn those into 90-day projects, and we're going to utilize the Plan, Do, Study, Act. We have created forms to help usher folks through the projects. And these are just some sample projects I've listed here from each of the priorities. And this is that Plan, Do, Study, Act cycle. So you can see where you take time to plan, do it, study your results, and then based on those results, as I mentioned before, evaluate next year's strategies.
So this is actually our last slide. So this one is kind of it says call to action. I'm going to say this is our kind ask for your support in holding us accountable to continuing to drive towards these priorities. Recognizing that there was considerable input from this board in driving the formation of these priorities, and we recognize the impact and the importance of this governing board asking us repeatedly how we're doing as it relates to these 6 identified priorities. So one of the things we're going to do is we're going to make sure that we email a completed copy of the strategic plan to each one of you. And we're going to also make sure that it's posted on our website. And then we're currently working on getting it printed in a nice and more palatable format so that it can be distributed widely. But we want to be really intentional about making sure that it's accessible to the community and that it is also readily available to all of you.
That's all we got. Thank you.
I'm interested, how much, until you get what you call the pretty version, can you send us that to have?
Yeah, and we can send you the full strategic plan probably later today.
Yeah, that was my other question. How much paper is behind that?
So the strategic plan is 25 pages, and then we deliberately created a strategic plan that was useful.
Okay.
So there are a lot of appendices and a lot of supporting documents that are attached that I think the total is about 65 pages, but the actual strategic plan was kept concise and nimble, so it's about 24 pages long.
Okay. Can you send both? 65 is short.
Yeah. So we'll send the entire thing, and the first section is the actual strategic plan. We tried to make it easy to just peel out what you need and set the rest aside. So.
Part of the reason for all those appendices too is that there are accreditation standards that require that you include the methodology, the planning process, that sort of thing, but that's maybe not as relevant to a wider audience.
Mm-hmm. No, I was thinking 3 digits, but 65, I was like, oh.
Yeah, we tried to keep it much
Efficient.
more efficient, useful.
Jamin, how often do you think it would be appropriate to report to the board, like yearly, in terms of?
Yeah, I
having
think
these-
annually is probably.
I don't remember
I was
exactly.
wondering about the 90.
I think
We
we're
can,
able to.
I mean, we can give highlights on 90-day projects as they roll out and give like overviews on how those 90-day projects are working. I think that would be reasonable.
Part of like the department report survey.
Yeah, we can include it in the department reports, yeah.
Just a comment, I think that would be helpful, especially if the goal is for us to hold you accountable. We would need to have more than an annual update to be able to do that.
Makes sense.
We can do that, absolutely.
Okay, thank you.
Thanks.
Item B, community health assessment data presentation. Dr. Yee.
Good morning. Give me just a moment to get this all pulled up here. We are going to share this. All right. I'll tell you what, these bars that go across the screen are so much fun. We're good. All right. There you go. All right, so I'm very excited to get to present to you today on the 2024 Community Health Needs Assessment. And this data has been released widely to the community. I think February was when we were able to kind of put that out and start having some community conversations around the data that was found. I am using the PowerPoint that was put together by PRC. Just to make sure that I cover kind of what everybody else has heard and seen. And I kind of set today's agenda up as kind of a warm-up act, if you will, for next month, which is State of Public Health. And I really wanted you to, be able to see the strategic plan and the community health needs assessment data, because all of that is going to kind of marry up into that State of Public Health with some deep dives into some of the data and talking about prioritization of some different things. So I wanted to basically give you an appetizer so that you're ready to roll next month when we have kind of that big piece that's coming. So as you know, the community health assessment that we do every few years is sponsored and supported by a number of agencies, including obviously the health departments, but also our major health systems here in the Metro and our FQHCs. So we are very happy to have all of their partnership. And then of course, this is the last few iterations have been facilitated through the well-being partners as well, so we're grateful for their assistance. Just a little bit on this assessment. So we use a couple different kinds of data when we're putting this together. Lots of secondary data, which is county level, and then also using census data, vital statistics, other kinds of data that are out there through a variety of sources. One of the big pieces or big information sources is the actual community. So we do reach out to key informants, which are community stakeholders, and get their feedback. And then we also reach out to the people who live here as well. So we do have the voice of the residents of the Metro that are giving us input into what their health looks like, how they're experiencing health or disease, and really, we're able to kind of use that to start to tease out some priorities, take that data back to the community, and hopefully hone that down to where we should really be focusing. A little bit more on the population survey. So across the Metro, there was 3,651 surveys. And again, those are stratified across a bunch of different areas, including Douglas County, Sarpy, Cass, and Pottawatomie County. And that final sample gets weighted in proportion to the total population. And that's just so we can compare apples to apples and hopefully have a data set that's very representative of what our community actually looks like. Oops, sorry about that. This is population and survey sample characteristics. So this is who was surveyed. You can see the breakdown, women, men, age groups, and then race, ethnicity, and then income status. This is kind of the meat and potatoes, I guess you could say, of what came out of that assessment. So these are areas of opportunity. There are things we're also doing well, but these are really, since we use this as a really important document to help us drive our future strategies and our future programming and how we're collaborating with our community, we really like to look at those areas of opportunity. The ones in red that you see here are the ones that have floated to the top as highest priority. I don't have those ordered yet, so we do have some data from the public that we're working on putting that together. If I had to predict for you, I would say that mental health and substance use are probably going to float to the top. And as you know, mental health has been at the top of the community's priority list for a number of years now, so I don't see that changing. And I think the data that you see in here today probably is going to support that as well. So that's just why you have some red ones. Those are really the areas that the community, as we looked at that data in the surveys, that really kind of floated up to the top as priority areas. So we'll start out talking about general health status here today. This is self-reported health status. So this is a question asked on that survey of the public. So this is what people are actually telling us about how they feel about their health. So what you'll see is only about 13% of the community would rate their health as good or as excellent. And we've got 12.8% rating as fair and 3.5% rating as poor. And if you look a little bit closer at those categories that are people who are experiencing perhaps poorer health, this is what that breakdown looks like by where they live. So you'll see that Pottawatomie County maybe has more people reporting poor health. Douglas County here, we're at about 15%. And overall for the metro, you'll see that the number or percentage of people who are reporting fair or poor health has actually increased from just shy of 13% to just over 16%. This is the same data but broken down by some demographics. So you'll see that men, people over 40, those experiencing low income, and our LGBTQ plus populations were the ones most often reporting fair or poor overall health. I do want to just note that this is the first community health needs assessment iteration where we actually asked about LGBTQ plus, which has been pretty eye-opening. I would keep an eye on that as we go through here because I think it's very telling as we go through in terms of who in our community is really struggling for access and struggling to get their particular needs met. Quick conversation about access to care. So one of the questions we ask is around barriers to access. So that's really being able to access medical care in the past year. We're overlaying this on some previous, so you won't actually see those little bars. They don't, were they? Oh, there they are. I just had to click another time. So the pink bars are in the past, the red bar is for 2024, and then blue is comparison with the United States. So you can see how the metro area is faring. So increases in every category in terms of difficulty getting access to medical care. So the most commonly reported is difficulty getting a doctor's appointment, and then that's followed by inconvenient office hours, cost, and finding a doctor can be a very difficult endeavor as well. And then we have quite a few people also who say that lack of transportation to actually get there remains an issue. And then just an interesting note is 17% of adults have skipped medication doses or stretched their medication doses out. in order to make it last longer, in order to save costs on their medical care, which is really, really unfortunate. This is experiencing difficulties or delays in receiving needed health care in the past year. So those reporting that have increased pretty dramatically, 33% back in 2011 versus 42.2% today. And this is who we see reporting most commonly this issue. So you'll see women, the young adults, so 18 to 39, those experiencing low income or very low income, our Hispanic community, and then our LGBTQ plus population. Again, you'll see that's quite high. Of note, we've also seen an increase in ER usage for non-acute issues. So we see more people who are using the emergency departments around town as ER, emergency room, yep. Oh, sorry, ER. The emergency departments around town is kind of their method of seeking medical care. And so that can be a kind of a canary in a coal mine, if you will, to indicate that people are having trouble accessing primary care services elsewhere. Some other areas of opportunity. Cancer remains one of the leading causes of death here in the metro area, 19%. Interestingly, I had the pleasure of going through some old, and I mean old, Board of Health reports, going back to the 50s, and I believe the top causes of death that we see now are many of the same causes of death we saw back in 1950. So while we've made some pretty amazing progress, we've also seen just a true struggle in really decreasing some of these issues in our community. I do want to note that this particular data is a little bit old. So you will see that this was in 2020, most recently updated, which was, it looked probably a little bit different in that COVID was up there as a top cause of death. That has dropped, I think, significantly here now in 2025. This is age-adjusted mortality by race, so we're kind of evening the playing field in terms of age, because we know some ages experience, cancer deaths or different kinds of deaths differently. And so if we're gonna look at it across the board, we have to age adjust. And our Black non-Hispanic community is experiencing higher rates of cancer deaths than the rest of the population here in the metro. In order to, yeah. This one? Per 100,000, yes. All right, so in order to prevent cancer, we have to screen for cancer when we can. And so none of these are new or surprising in terms of the screenings that we offer in the medical community. So here you'll see that breast cancer screening has remained pretty static over the years. So there have been some little ups and downs, but by and large, if you're eyeballing a trend line, breast cancer screening has remained about static. We are above the Healthy People 2030 benchmark for that, so that's good news, and we are doing significantly better than the United States there, so that's good. Colorectal screening, actually our rates of that have gone up a little bit, so we're happy to see that. Again, we're doing better than the United States, but when you look at cervical cancer screening, we see that this particular screening has not stayed static, it has not increased. We've actually had a fairly significant decrease in people who are getting those cervical cancer screenings. So we dropped from 86.7, which was above the Healthy People 2030 goal, down to 73.5, which is below that goal. So that is an area in which a little bit of work needs to be done. Looking at diabetes, this is our prevalence of diabetes in the area. Northeast Omaha is seeing the highest rates of diabetes, and our overall diabetes numbers have increased. The prevalence has increased a little bit over the years, but not significantly. So we were 10.6 back in 2011. We're at 11.2% in 2024. So just a small increase there. If we look at that demographically, we see that men, those over 65, The especially low income and then our Black community are having higher prevalence of diabetes than the rest of the community. Another note is that about a little over 12% of adults in the metro have been diagnosed with prediabetes, so that's kind of that precursor, and that is actually a significant increase over what we had seen previously. So we have more people who are kind of moving into those diabetic areas. This is looking at physical activity, nutrition, limited. This is those who report limiting their, or I'm sorry, I went too fast. Disabling conditions, thank you. All right, so this is people who have reported having to limit their daily activities in some way due to a physical, mental, or emotional problem. And I think that the trend line with this is pretty noteworthy in that we went from 18.4% of people surveyed having limitations in their day-to-day activities because of their health, all the way up to almost 30% in 2024. So that's a very significant increase in those who are reporting that. This is the demographic breakdown that you see for the metro area. So older individuals, so over 40 basically, low income again. Both white and Black individuals reported this at pretty high rates. And then LGBTQ plus individuals also report at high rates that they're unable to basically live their day-to-day activities because of their physical health. Alzheimer's disease stuck out as something that we're seeing some pretty significant mortality trends with, so we put that in here. So for the metro, you'll see that we're above the Nebraska rate, the Iowa rate, and the United States rate in terms of deaths related to Alzheimer's disease, and that has been going up over the years. Heart disease and stroke. Leading causes of death, this is that pie chart from earlier that you saw, so going into heart disease, which is another very common cause of death here in the metro. Here you'll see heart disease, age-adjusted mortality by race. Our Black residents are experiencing heart disease mortality at much higher numbers than the rest of the population, and again, that is also true for stroke mortality, so deaths due to stroke. And overall, the prevalence of heart disease and stroke have increased over time for the metro. A quick note on infant health and family planning. This is an area that floated to one of those top 6 priorities, if you will. So right here, we're looking at lack of prenatal care in the first 6 months of pregnancy, because we know that being able to access early and good prenatal care really impacts the health of the pregnancy and the health of those infants when born. And so what we see here is that in terms of where we stand compared to the US, we're doing better than the United States, but we do have rates of people being unable to get that care in the first 6 months increasing. So that's not great news, especially given our very significant prioritization of our fetal infant mortality review team, and really looking at the disparities that we see in death rates between Black babies and white babies, Black moms and white moms, knowing that we have an issue with that disparity. And so that data isn't reflected here because we've presented it elsewhere, but we did want to highlight that prenatal care seems to be an issue that has been getting worse. Next, we're going to talk about injury and violence. So here we're looking at falls, ages 45 and older. It's a little scary being in that age group now, where falls are a thing that we measure. But we have seen more falls in our over 45 population than we did a number of years ago, so that rate's gone up from about 30% to over 35%, unfortunately. And if you look in the metro, 38.3% were actually injured as a result of a fall. So you can have some falls that perhaps didn't lead to significant injury or disability, but almost 40% of those did have some kind of an injury that was associated with that. This one is about intimate partner violence. And again, this is one that really stands out. You'll see that the reported rates of intimate partner violence have increased since 2011 pretty significantly. We were at 12% previously, and now we are almost at 20%, which is pretty significant. Mental health, again, that's going to be one that's going to float to the top. In terms of those experiencing fair or poor mental health, you'll see that those rates increased significantly in 2011. It was about 9% reporting, and as of last year in 2024, 22.7 experienced fair or poor mental health. We also saw rates of diagnosis with a depressive disorder increase from almost 20% to over 32%, so that's also pretty significant. And then those who have experienced symptoms of chronic depression, we've also seen that skyrocket from 25% up to almost 42%. About 28% of metro area adults are receiving mental health treatment, which is twice the rate that they were in 2018. So I think this one is really interesting because when I saw this, the first question was, well, what's driving that? Is it actual increases in mental health disorders or mental health problems, or are we talking about it more? And so people are more willing to report it. I don't have the answer to that. It's probably a combination of a variety of factors, but it's good that we're recognizing and seeing this so that we can continue to prioritize and really come together as a community to find new ways to support mental health. This is moderate to severe anxiety and depression. You'll see that this rate went up in the metro area from 15.6% in 2021. Remember, we were in the middle of a pandemic then, up to 20% today, or last year, I should say, in 2024. This is the demographic breakdown. Again, you're going to see that LGBTQ+ population really standing out as a population that is disproportionately experiencing moderate to severe anxiety and depression. You'll also see our Black community reporting high rates of this, our very low to low income individuals, those young adults, so between 18 to 39, and then women report moderate to severe anxiety and depression more than men do, but certainly we have plenty across the board. We also like to assess whether people have someone that they can actually talk to and turn to when they're having a difficult time. And you'll see this, this trend has decreased. So in 2018, over 86% of those surveyed said that they had somebody that they could talk to if they were having a hard time, someone they could turn to for help. That's down to 74.6% in our current iteration. This is suicide, age-adjusted mortality trends, so really the trends in terms of those dying by suicide. You'll see that the metro area is lower than a lot of the rates, so but increasing, unfortunately. So if you look at Nebraska rates, we're approaching that. Iowa rates, we are below that. And then the United States overall rates, we've actually met that. So we are about on par with the rest of the United States at this point in terms of suicide deaths. And the increase is what we really want to note and point out. This is those reporting that they're unable to get mental health services when they needed to in the past year. And you'll see for the metro area, that is a very significant increase. 2.7% back in 2018, up to 11.8 currently. here's the demographic breakdown of that. So women, younger women, low income, and our LGBTQ plus community really struggle with this. Moving on to nutrition and physical activity and weight. This is another one that floated up into the top 6 as areas of concern for the public. Prevalence of total overweight, so that includes overweight and obese here in the metro area. We've increased from 2011 to 2024. We were at just over 67%, and now we're over 72%. 34.8% of metro area adults are found to be obese, and that was also a significant increase over time. So that's just separating out kind of the top end of the overweight status. When we talk about people meeting physical activity recommendations, the benchmark is 29.7% or higher. We're not quite there yet, so we started out at 22% in 2018. We have increased to 26%, so that's pretty good. We definitely still have some room to grow there to meet that benchmark and to continue to encourage and help people to meet those physical activity recommendations. And we ask why people might be struggling to meet those recommendations, and here's what we heard in terms of the presence of barriers within their neighborhoods that prevent physical activity. The pink bars are past years, 2024 is the current one, if you will. Lack of sidewalks or sidewalks in poor condition we saw some bigger increases in terms of heavy traffic being a limiting factor in people getting out there and moving within their neighborhoods, lack of trails or the trails that are existing being in poor condition. We see crime rates being a concern, and then lack of street lights or non-working lights in a community, which can definitely contribute to feeling of safety or not. And so those were things that we saw increases in, unfortunately, in our survey. The areas we saw these answers most frequently was in East Nebraska. Yes, East Nebraska, but more specifically, eastern parts of Omaha. Oral health. So this one indicates those who have visited a dentist or a dental clinic within the past year. The goal we are reaching for is 45%, and I'm very happy to report that in the metro, we are above that. So we have decreased, though, over the years. So 70.4 back in 2011, down to 67.4% in the current measured year. And so that is certainly something we don't want to see continue. We don't want a decreasing trend in this. We want to assure that everybody is able to access dental care. You'll see that Eastern Omaha tends to be an area with less dental visits. Pottawatomie County, I'm not sure why they highlighted that one. Oh, they're the ones with the least amount. Sorry about that. So they are experiencing lower levels of dental care than the rest of the metro area. And this is just that demographic breakdown for you in terms of who has been able to get into the dentist and who maybe struggles to get into to see a dentist or to access dental care. So I don't think there are too many surprises here. We see that young adult population, low income, and then Hispanic, Black, LGBTQ plus, certainly. And just a very quick note for you on diverse races. This was, I think, kind of one of those areas where it was those reporting 2 or more races, or something that didn't fall into the Hispanic, White, Black, Asian categories. So unfortunately, those are all kind of lumped together, which is something we will be changing for the next iteration of the community health assessment. A quick note on respiratory diseases. Prevalence of asthma in the metro is one of the benchmarks we like to use for this. We have seen asthma rates increase across the metro up to 12.5% from the 8.6% it was in 2011. Social determinants of health, I was kind of excited that this actually floated to the top as one of those 6 priority areas, because it tells me that people are thinking in terms of social determinants of health. So it's those upstream factors that really influence overall health. So it's encouraging to me that people are at least thinking in terms of kind of those foundational drivers. So the metrics that we've used to measure this, first one, whether people have cash on hand to cover a $400 emergency expense. That has actually increased, so that's not good. 18.7% back in 2021 said that they didn't have that, up to 24.3% now that would not be able to handle a $400 emergency expense. That is better than the United States. However, we act locally. We pay attention to our local situations, and the fact that that is increasing is an indication that perhaps socioeconomic status is getting worse. Always, usually, or sometimes are worried about paying rent or mortgage. Over the past year, that's a very significant increase, up from 20.1 now to 32.5% of those respondents saying that they worry and have anxiety around those issues. Again, better than the United States, but still that trend is concerning. Unhealthy or unsafe housing conditions in the past year has also increased pretty significantly, more than doubling from 2018. And each of these indicators disproportionately impact our low-income residents, which I don't think is a surprise, and people of color and the LGBTQ plus respondents. We also measured the perceptions of unfair treatment in day-to-day life. So it's a little disheartening to see that people are perhaps experiencing or perceiving unfair treatment at higher rates in the community than they did previously. 28.2% reported that they feel like they've been treated with less courtesy and respect. 17.8% treated as less intelligent. 10.1% received poor service at restaurants and stores. A small increase in those who report being treated as a potential danger. And then 7.4% report being threatened or harassed. And there are very clear disparities if you break this out by race, ethnicity, and income. This was an ACEs year, so we did ask ACEs questions on this survey. We don't do it on every iteration. I think 2018 was the last one that we did, if I remember correctly. We did do it again this year, and so this is each of the individual ACEs variables, and you can see that emotional abuse has been reported by almost half of those who responded, followed by household substance use, separation or divorce, mental illness within the household, physical abuse, intimate partner violence, sexual abuse, and then having a household member who is incarcerated. So we typically look at all of their variables when somebody actually takes an ACEs, and if they have 4 or more that they're reporting positive on, that's considered a high ACEs score. Say again.
What particular makes the ACEs years? Time span or just?
Ever. So you're looking at childhood. So
No, I mean, 18, it happened in 18, you said. Yeah, what triggers it? Just every 10 or 8 years?
Oh, when we actually do the
Yeah.
ACEs? Well, I can tell you because I was in on the discussions, there's not a standardized like time interval that we're necessarily using, but because mental health is something that continues to float up to the top locally, we thought it was really important that we get a better handle on ACEs and really where traumas are happening for our residents. And obviously, we can't change the ACEs scores for those who already have the ACEs scores, but maybe that helps us be more targeted in our interventions for our current youth and trying to decrease those ACEs variables for our children that are currently being born. So we're not going to necessarily see a change in the adults. I mean, once you have an ACEs score, you have an ACEs score. But hopefully, if we know, boy, this is really, looking at that, let's just take household substance use, for instance. Gosh, 34% of our respondents had a positive answer on that. We really need to do more education and more intervention with families, perhaps, to decrease substance use. So then hopefully the children being brought up in those homes aren't experiencing those ACEs variables. So over the very, very, very long term, we want to see our community's ACEs scores decrease.
So I'm assuming that's kind of retro in the fact that 21, mental health was a big thing. They did the deep dive on mental health.
Yep.
And this responded to that. So I'm assuming because mental health is high this year, I'm safe to assume you'll do the ACEs thing maybe in 2027.
Possibly, yeah.
Okay.
Yeah.
All right.
It just depends. But that is what drove us including it this time, was really feeling like we needed to have a better handle on how trauma is impacting those mental health concerns in the community. So, talking about ACEs scores, who has the higher ACEs scores? So this is, again, that 4 or more. We saw that a pretty significant increase in adults in the metro that are reporting more than 4 ACEs. That can be due to a lot of different factors. Our population is growing, so possibly we just have more people in the community now who have more than 4. We are also talking a lot more about trauma, trauma-informed everything, mental health, first aid. There are a lot of initiatives out there to help us to decrease the stigma around these ACEs variables and talk about them more. So it could be that people are perhaps more willing to answer these questions, and so we're detecting more of it. But we did see a pretty significant increase from 2018 on that. And then this is the demographic breakdown. Again, I don't think any surprises here. And again, I really like, to point out, because it is a newer variable, and goodness, it's good that we're asking the questions, because our LGBTQ plus population really is experiencing a lot of disparity. The relationship of ACEs with other health issues. So this is basically, looking at whether people who report high ACEs also have other coexisting health problems. And so you'll see that depression history and healthcare access barriers are a couple of the highest areas where you see both of those occurring. You'll also see housing insecurity happening much more frequently, and then having mental health treatment also is kind of associated with those having higher ACEs scores, which isn't necessarily a surprise, but it is always interesting to see it actually on paper and to confirm, kind of where we think these kinds of coexisting issues are. All right, areas of opportunity, again, looking at substance use. This was one that floated to the top again in terms of priorities for the metro area when we asked the public. This is alcohol deaths, age adjusted, and you can see the metro area is far higher than other benchmarks with Nebraska, Iowa, and US. We also noted that this is much higher, the mortality rate is much higher locally among our non-Hispanic Black residents. Unintentional drug-related deaths. We see that in terms of drug deaths, we are not significantly over the United States. The United States definitely has more significant of drug-related deaths than we do here in the metro. However, if you eyeball that trend line for us in the metro, you will see that our deaths attributed to drug use have actually increased. So that is something to be on our radar. And our last area of opportunity is around cigarette smoking. So well, smoking, we'll say that. Smoking has actually remained somewhat static with a bit of a decrease since 2015, so down to 14.8 from 17%. However, vaping has increased. So that is, and that is actually not that surprising because we often see people who view vaping as a safer alternative to using cigarettes. And so they will try to quit smoking cigarettes by transitioning to vaping. I'm not necessarily too surprised to see that increase, even though it's a pretty significant one. And because of how vaping is marketed and has less restrictions on it in terms of that, we do see quite a few youth using vaping products. They're flavored, they're not as harsh in terms of their odor and things like this for youth. And so you do see a number of youth initiating vaping. And so seeing that increase is just it's not very surprising, but it definitely is concerning and tells us that really, this is a kind of a new front on which we need to fight the smoking battle, if you will. Okay, I feel like I whipped through that really fast, but I did because I know you guys have time constraints. And so I am very happy to answer any questions. If you have specific questions about data and you want me to reach out to Mr. Lockwood about it, I'm very happy to do so, but I can also answer most of your questions here now if you have any.
Yeah, one. Do you know if the survey this year, like the sample size or maybe the way that we tried to get people to take the survey changed at all?
It did.
Quite a bit?
It did. So previously it's been a phone survey where we literally had people calling and doing the survey with people over the phone. This year we also had it in an online format where people could go online and actually complete the survey that way. We still had people calling for those who didn't want to do it in the online format, so we did still have those calls going out, but this was the first year that we had that virtual option, so it did change in that respect.
And the number of respondents, how much did that change?
I think it went up. Leah, do you remember back in 21 what our survey respondent number looked like? I think it did increase a bit. I can get that number for you, but I don't remember. I got here when we were doing the chip, and so I didn't.
I've done work on the pediatric version, and PRC typically sets like a threshold that indicates that it's a relevant sample for the community size, and so it's not a matter of percent of response, but getting enough responses to hit that threshold, if that makes sense. So as our community grows, as that threshold increases a little bit. So
yes. What's that? Yes. Yes, we did.
And can I I'm sorry, there was one other significant change. This was the first year where the phone survey actually went out to cell phones. So prior to this iteration, they would only make outbound calls to identified landlines. So that was another significant change.
I will say it's a very long survey, and it's great that we have a lot of data that we can compare from year to year. But I, just in conversations with the Regional Health Council, would anticipate that we'll probably try to identify some areas where we can consolidate questions and not ask quite as many. If you are interested in reading the entire community health assessment, it is on our website, and it's like 200 pages. So pretty long, but a lot more information in there if you're interested in digging in. And then those priority areas that we talked about, kind of those 6 that floated up, as being ones that seem to be of most concern. I actually gave those to my data work group, and I think they just completed their deep dive into those areas, so you'll hear more on those during the State of Public Health.
Are you going to produce a report from that?
What's that?
Are you going to produce
Yes.
a report from those deeper
It'll
dives?
it'll be part. Right now, it's envisioned as part of the state of public health. However, we could very easily publish that as kind of an addendum, if you will, to the actual community health assessment.
Yeah, I think that'd be helpful.
Sure.
I have a few questions.
Yeah.
I saw that you broke out the LGBTQ plus community, which is nice to see.
Yeah.
Are there any plans to also do the same for the refugee groups? I know that they tend to get aggregated into the Black, Asian groups, but as we know, refugees have a unique experience in terms of their health conditions and their experiences that would make sense to tease out. I know that the state used to do, well, they did, but it was like back in 2017, 18, 19, somewhere around there, that they did a report, but there hasn't been one released since then. So I'm just curious if there's plans for that.
You know, we haven't discussed it, but I think it's a great suggestion. I really like that. I'll make sure that we pass that on.
Yeah, I think that they are experiencing some very unique health conditions and issues that need to be addressed. And if we're pulling it out for LGBTQ+, we should pull out for them too. For the cancer screenings, are they broken down by race, given that Black residents experience higher mortality rates as well as incidence rates?
I believe that's in the full report. It's not on these slides, but I believe it is in the full report. They tried to keep it condensed for the actual presentation portion.
Well, that makes sense. I was just
But
asking.
yeah, I think it's there.
And then last question is, why are we not breaking down obesity and overweight? Why are they still continue to be aggregated? I think it should be treated like pre-diabetes and diabetes, given that it's an opportunity to prevent them from becoming obese, if we know that. So I'm just curious as to why we continue to do that, and if there's any opportunities or plans to change that for later renditions.
I don't believe it was discussed, to be honest. I'm thinking back, and I don't know that we ever asked PRC to break those down. They could be broken down. I apologize, it's been a couple months since I read the 200-page report. It could be in there broken down.
It's not.
Oh, okay. Thank you. I will certainly suggest that as well, that we're maybe looking at those separately instead of lumping them together. I know they mentioned that there was a mention of the percentage that fell into the obesity category, but it wasn't broken down by any other variable, it looks like.
Yeah, I think that's important as we move forward and obesity rates continue to rise. So we need to kind of get ahead of it by knowing who's overweight before they become obese.
I would anticipate that there will probably be a larger focus, again, on chronic disease in the future. And so I would imagine that we'll probably prioritize breaking some of those things down. So prior to COVID, we actually did pay quite a bit of attention to chronic disease, and our focus really had to shift. And so now I think we're starting to talk again about some of those more upstream issues that we can act on to prevent the severity of disease down the road. Yeah. Thank you, Dr. King.
Dr. Hughes, to build off what Dr. King said about the kind of post-report, can you all plan on, because I figure there's some I think some opportunities here. I'll wait to see what next month says when you break that down, but there's also, I think, if out of that strategic plan you're going to do this foundation, I think you need to plan a road show to some particular places that kind of build this awareness up for the foundation acts. But also too, I kind of want to be on the offense a little bit, being that you got a lot of stuff happening nationally. I'd like to take this and be on the offense a little bit locally.
Yeah.
And also give some thought about how to tee it up for the new city administration.
Yes.
Because he served on Drew's board for the last 12 years, so he's aware of the health stuff.
Yeah.
And
already been thinking about that.
Yeah, and there's an axe to him, but I needed to set up a little better and leave him to get settled, because I'm thinking about asking him to have an agreement with the Board of Health to have you as the director sit in on their cabinet meetings to see if he can incorporate the health piece overall into the bigger piece. But you need to tee it up a little bit better.
You got it.
He'll be receptive to that. Okay.
Great.
All right. you want to just mold on into your?
Sure.
Okay.
I actually don't have a lot for you this month in terms of director's report, so that's good news. I will tell you our employee parking lot, which we've had a number of hazards in for some time, is being fixed right now, so we're very excited about that. We actually had somebody who came in for a food truck inspection and tripped because of the uneven cement back there, and so thankfully it's being fixed, and hopefully it's much safer, especially for our employees who are back and forth from the parking lot to the door on the lower level. So happy about that. I also wanted to let you know about the launch of Credible Mind and give huge kudos to Leah Cassidy for her amazing work and her team's work getting Credible Mind up and running. So this is a fantastic online platform that provides mental health assessments or wellness. So mental health and wellness kind of lumped together. There's assessments, so you can look at, if you're experiencing burnout or anxiety or depression or grief or a number of issues. There's assessments in there. There's ways to set up self-care plans, and then connecting to local resources. So if you need more than what you can accomplish on your own, and you really feel like you need more
Dr.
support.
You just for the you want to take the slide
Oh,
down?
sorry. Yes.
Since you
Thank you for
transition.
that. And so that platform is up. It's live. You can link to that. You can get the link to that on the front page of the health department website. It's pretty fun to play around in. And it has a number of local resources. So we're so excited to kind of have an area where people can go, they can actually see what those local resources are, and hopefully be able to tap into those more easily because it's all in one place. And it's just a great platform. We were able to even develop a PSA launching this at the Storm Chasers, which Leah was a great voice for that. Thank you for that. And we're just really excited to see how the community uses this, and hopefully we'll be able to report to you in coming months about some numbers around how that's being used. Sarpy County, Sarpy-Cass Health Department also has Credible Mind, so we have most of the metro covered with this resource. Anybody can get into this resource and use it, so even somebody in Scottsbluff could get into it. It's just that the resources that it points you to are local to Douglas County, so that wouldn't be as salient, perhaps. But we're very excited about that.
Can I ask a question about?
Yeah.
So what was the rationale for why that was started, and what efforts were made to partner with other organizations that are also doing similar things? I know, and I think you all are aware, the Wellbeing Partners had their whole, they have their whole mental health campaign. So I'm just curious if there have been efforts to partner so that there could be more visibility around how this particular effort, I guess, I don't know what you want to call this, is being made.
So the Wellbeing Partners already is doing some things in the community, absolutely. They do a lot around like workplace, wellness. They
have a mental health campaign.
Yes. And so this is really more of a tool, if you will, than a campaign. So it really is a tool that you can go into, you can take an assessment, you can get feedback, personalized feedback based on that assessment in terms of like, here are some things that you can do to improve the areas where you're having issues. The campaigns, I think that the Wellbeing Partners does a great job, especially like destigmatizing, talking about mental health, kind of engaging conversations in the community around mental health and things like that. This is just a tool. It's just another tool for the community to use. Yeah. The reason that we went with that is because a number of other Nebraska health departments also were going to be using it, and so really having kind of consistency in the resources that are available made a lot of sense. And given the fact that we have limited resources in terms of how much we can do with the people that we have, this is really a really good bang for our buck in terms of helping people become more educated about their personal situation.
Yeah, so the point I was making is that when there are these other opportunities that are happening in the community. And yes, it is a mental health campaign, but the fact that they're raising awareness about mental health, it would have been a nice partnership. Then you could point them to Credible Minds, depending on if you would have partnered to make something like that happen. I'm just seeing a lot of these kind of activities are happening in silos versus trying to figure out how we could still maximize those campaigns in order to bring more traction and attention to, what's this called, Credible Minds? To bring more attention to that. So that's the point I'm making, is that there's opportunities. I know that they're separate, but there's overlap. And so I think it's a missed opportunity there to have done something with that, to have a little bit more visibility and traction.
Appreciate the feedback.
Okay. You going to legislative?
I'm done. Oh, legislative update. Yeah. So the big one, of course, is LB 261, and that is in the governor's hands. He is due to complete that by midnight tonight. As far as I know, governors like to have that in hand as long as possible in case there are any line item vetoes. I don't know of any that are happening. That doesn't mean that they're not. However, at this point, the bill as it was presented to the governor was a $3.5 million cut to public health across Nebraska. For us, that is between $500,000 and $700,000, which is down from the 1.9 that we thought it was going to be. So I guess that's good news. It's still painful. There's still some decisions to be made and some tightening of the belt to be done in terms of what that means for our budget. Luckily, this doesn't touch our healthcare cash fund monies that we get from the state. This is to really the monies that we have received since the COVID pandemic. So we call them 1008, which is, of course, the initial bill, I think, that started bringing that set of funding in. Mm-hmm.
Can I? So I'm assuming this 1 million. So there was the community, there was the healthcare cash fair money, and
Yep.
then right after COVID, Vargas did some money.
And it's
This 1
general
million
fund.
is Vargas's money. Okay,
Yeah,
all right.
it's general fund. So basically, the general fund monies are what we see being cut. So that really was flexible funding for us to spend on infrastructure and things like that. Luckily, we had moved positions out of our general fund or 1008 account, if you will. So at this time, in terms of positions, we're doing okay. It will, of course, cause a drain in other areas, but we, at this time, are okay.
So best case scenario. Right?
Yeah. Yeah. So again, the governor certainly could still line item veto that and ask for that $4.5 million cut that was originally proposed in his bill. I don't know that that's happening. I haven't heard any rumors about that or anything like that. So right now, it looks like the $3.5 million cut to Nebraska public health departments is what we're looking at. And we won't know for sure till probably later today. Legislative session is ongoing. So I'll be able to finish that out, I think, for you in June.
Any questions from anybody on department reports? Okay, seeing none, we do have need for executive session for personnel matter. We know for the record that the next meeting of the Douglas County Board of Health will be on June 18th here at 8:30. And with that, is there a motion to move into executive session for personnel matters?
So moved.
Motion by Wilkin, is there a second? Second by Weiss. Roll call. And just know for the public, when we come back out, we won't be taking any action. So if anybody needs to go, they don't need to hang around. Roll call.
Weiss. Yes. King.
Yes.
Rogers.
Yes.
Wilkin.
Yes.
Wade.
Let me see what it feels like.